I'm Dr. Mark Gold, and this is the Gold Standard.
I'm here today with Dr. Brian Fuehrlein, and we're just going to have a discussion about Dr. Fuehrlein's career, the impact that his career has had in addiction medicine and psychiatry, and what he sees for the future. And we'll probably get an idea here or there about what he thinks about the current state of research and practice in the United States. So, hi, Brian.
It's great to see you, Dr. Gold.
It's great to see you. How do you look so young and have that job at Yale where you train all of these addiction psychiatrists and have maintained your #1 ranking in the United States in addiction psychiatry?
Yeah, the looking young, I think, is a function of Zoom more than anything else. But I do work hard. But yeah, we've done a good job here at Yale. We've trained a lot of addiction psychiatrists. We have an excellent program. So the future's bright. I think we've turned out a lot of good doctors.
So how does that happen? I mean, how does Yale rank #1 in addiction psychiatry?
It's an interesting question. Fellowships in psychiatry recently have not been particularly competitive. Many spots don't even go filled, actually. Across the landscape nationally in addiction psychiatry, about 50% of the spots, I may be a little bit off with that number, but about 50% of the spots don't even fill across the country. Somehow Yale has been able to fill all of our spots, and we have the largest program in the country. When I was a fellow, we had, I believe, 7 total fellows. 5 or so were housed at the VA, 2 were over at Yale proper doing other things. Now I think we've increased that number to 9 or 10. I lose track of the exact number because we also have some research people. I think it's a combination of having so many experts who stay local to the Yale system. And it's a combination of the research, the administration, the support that we have. It is a decent place to live up here in the Northeast because there's so many people around, so many experts, so much to do. So we've done a really good job of maintaining our reputation, our quality, training, and our ability to recruit top people, even in an environment where many people are skipping fellowship to go into practice directly.
Well, it's just interesting for me. I mean, aside from having you and the history that the two of us have together, of course, I was at Yale at 1975, and there was no such thing as addiction psychiatry. There was no such thing as addiction medicine. We didn't have a fellowship. And actually, for me to get trained by Herb Kleber, I had to moonlight. And my role at Yale was really to help run the translational research facility, which went from rats to monkeys to man, at the Connecticut Mental Health Center. We had tracks then, but no track in addiction. And in fact, when I decided that I would do this, many of my mentors said that it was career suicide since I was such a promising researcher. Things have really changed, haven't they?
Oh, I mean, things have changed so much. I mean, when I came to Yale for my fellowship, so I don't want to date you too much, but you were here at Yale just before I was born, not to reveal my age, but you were very close to when I was born. When I got to Yale in 2012 to start my fellowship in addiction psychiatry, I remember I counted the number of addiction faculty just at the VA. Keep in mind, Yale encompasses a lot more than just the VA. My clinical role is at the VA hospital. Just at the VA hospital, I counted somewhere around 17 addiction-trained psychiatrists on the faculty, not including the 5 or 6 fellows that we had, which is an astonishing number. So to go from where we were back when you were here in the 70s, with sort of minimal addiction work, and you actually me knowing you very well and knowing your career, you sort of pioneering a lot of that and getting to where we are today with so much resources and faculty and expertise and training and so many opportunities. And, it's quite remarkable how far we've come. We still have a long way to go, but it's remarkable how far we've come.
When you think about your career, like, is there a time when you were in training or before when you said, I'd like to be a psychiatrist?
Yeah. So I was at the University of Florida, as you know, while you were there. And so I did an MD PhD, and my PhD was in biomedical engineering. And I was always a math, physics guy. That was my thing. I actually wanted to be a professor of, physics or math or something. I loved teaching, and I loved physics and math. And that's what I thought I would do. While I was an undergrad at the University of Central Florida, I got involved in a research lab with 3D printing. And it was actually well before the common 3D printing we have now. We would print bones for orthopedic surgeons so they could practice surgery on. And it was a really cool, fun project. And it was medical, and I really liked it. And at that time, I met Richard Melker, who you know, and he became sort of a mentor of mine. And he basically convinced me to go to medical school, saying, oh, you're very interested in medicine. You could always do a PhD in biomedical engineering. Why don't you consider med school, not just your PhD? And it's a good idea. And I took a year off. I explored career options. I worked with people at UF. And anyway, I eventually got into medical school and did my PhD in biomedical engineering. When I finished that, I started clerkships. When I started clerkships, as a clerkship third-year medical student, I had no idea what I wanted to do for my clinical career, but I knew that I was an open book, and I wanted clinical work to be first. I wanted to love my clinical job. One of my first rotations was at Vista at the University of Florida with Scott Teitelbaum, who was a mentor of mine and someone you know very well. Scott Teitelbaum was my attending when I was a medical student on the Vista West, which was the addictions service at the University of Florida, one of the services. And I fell in love with it. I fell in love with addiction. I fell in love with substance use disorders, working with patients with substance use disorders, the complexity of the illness, how interesting the patient presentations are, how the doctor and the patient interacted, motivational interviewing, 12-step facilitation. I fell in love with that. And that's what I knew I wanted to do with my career, was go into something related to substance use. And that's when I decided I was going to do psychiatry as a way to get into addiction, basically. And I decided I was actually deciding between medicine and an addiction medicine fellowship, or psychiatry and addiction psychiatry fellowship. And ultimately, I thought the psychiatric comorbidities were more interesting, and I went with that.
So it's that's pretty interesting all by itself. So here you have this kind of hard science background. Most people think about people going into psychiatry as not being the most math science. I'm pretty much math science myself. And then you're kind of motivated by meeting Scott Teitelbaum, who is a lived experience addiction expert. Previously was a pediatrician, ended up being one of our physicians in the physician recovery universe, who has just done remarkably well and become the head of the division that I started down there. But that's just great. So just to move on that a little bit, but you took that kind of learning and his lived experience and view of addiction based on his experiences, and then added a lot of science to it. So, if you were to think about your main contributions to research, my mind, I start with, what do you do when somebody overdoses and they're in your emergency department? What do you do to help them live the next 6 months to 2 years? How do you get them started as early as possible on treatment? And how do you marshal psychosocial resources to help them, instead of saying, thanks for rescuing me and leaving? How do you get them to say, okay, I'll sign up for this program and try to change my life? Would you put that at the top of your list for your own academic accomplishments from a research to clinical practice point of view? Or did I just pick wrong?
Yeah, it's interesting because, like you mentioned, I came from a PhD in math science background. And when I chose what I wanted to do professionally, I knew that clinical care was going to be at the forefront. I didn't see my career as being a, first and foremost research. I knew I wasn't going to be an R01 primary research focused faculty member, that I knew I wanted to have a large clinical component to what I did. And that's what I do. And within my clinical world, I'm always looking for research that will improve patient care. I'm also looking at research projects that will improve the education for students and residents and fellows. So I sort of have had these two branches of my research, if you will, one being focused on the improvement of patient care, both in the emergency spectrum, but also in the addiction world, and two, which is the education of the future generation of our doctors, and how do we improve the education, reduce stigma, and things like that. So I've sort of branched into both ways regarding the opiate use disorder, the overdoses. You mentioned that my job is in a psychiatric emergency room. So I run the psychiatric emergency room of VA Connecticut. We have a large volume of patients. I'm sure we'll get into it in a little while, but we actually see cocaine probably more than we see opiates these days. I'm sure we'll get into that in a little while. But when we see opiate overdose patients reluctant to get into care, patients who just want to leave the emergency room even after an overdose, I think we've done a really good job. I've published in this space. I think we've done a really good job of trying to get patients onto a medication for their opiate use disorder, connected to care in either a residential program or an IOP type program. The VA, we're lucky. We have a lot of resources here, and there's a lot that we can offer veterans. And the difficulty with substance use disorders is motivating patients to do the next thing. Often they don't want to because their addiction is getting in the way. And I think we've done a pretty good job, both scientifically and clinically, of motivating patients and getting them into treatment. And the VA is fantastic for that.
So just to give us a quick thumbnail, like what do you do when someone shows up and they've just been rescued with naloxone or a similar agent?
Yeah. So we try to encourage everybody to get on a medication. So first of all, if I take a step back, we have a psychiatric emergency room. And at the VA, we're one of a handful of VAs in the country that have a completely separate freestanding psychiatric emergency room. Most VAs have a medical emergency room with a psychiatric consultant that would come over, but we have a separate unit. Because of that, we have a longer length of stay. We're able to hold patients several days if needed to get them stabilized. Whereas in medical emergency rooms, usually they have about a 6-hour window where they try to move patients out. So for us, the ability to hold patients for several days gives us the opportunity to stabilize them on a medication prior to discharging them and wherever they're going to go next. So a patient, let's say a patient is status post overdose. So a typical course would be they would go to the medical emergency room next door to us first to be stabilized from their overdose. They would call us and say, I have a veteran here. He overdosed on opiates. He's stable now. We want to send him over to you to get, stabilized on a medication or to get referred to what the next step would be. The patient would come to us. They might have some opiate withdrawal symptoms at this point, maybe not, depending on the reversal and the course, what they've been using and the time course. We will monitor them. We will typically recommend buprenorphine to start. I mean, it depends on a variety of things, but buprenorphine is usually the kind of go-to medicine for most of these patients. We will wait. The typical thing would be they go into withdrawal. We start buprenorphine. We can hold them up to 2 or 3 days if needed. And we would get them stabilized on usually 16 milligrams or so of buprenorphine. And then we would discuss with them the next steps of care. We have a whole variety of other resources that we can go into if you would like. But the typical progression would be overdose, stabilization, come to the psych ER, monitoring, initiation and stabilization on buprenorphine. Once ready for discharge, we then try to encourage them to do one of our residential treatment programs, which we have available here as a continuing level of care.
So if you were to have 100 people in that kind of a model, how many people end up being successfully placed on Suboxone?
Oh, I mean, if they're willing to, I would say the vast majority. I mean, we rarely have problems.
90.
Yeah, certainly. Of all patients, if a patient came in and said, I would like to get initiated on buprenorphine, I'd like to get, can you help me with this process? It's close to 100%. It's not common, with fentanyl now. We can have some speed bumps in the initiation of buprenorphine process. And there's a variety of people now that are doing high dose inductions, micro inductions with agonists. There's a whole variety of protocols by which people attempt to get people initiated on buprenorphine. We've tried some, but what's tried and true tends to still work the best, even with fentanyl. You wait until the patient has some moderate or so withdrawal, you stabilize them, and it usually works pretty well. And the vast majority of the time we can do it. The reason why we may not be successful is if the patient themselves says, I don't want to do this anymore. I just want to go home. And that's when we use some of the techniques that, that I learned from Scott Teitelbaum about motivating patients and try to keep them in treatment and things like that. But, obviously we're not able to convince everybody to stay and get the help that they need. But if they're willing, we have very high success rates.
Well, that's just great. So, you've mentioned already 2 mentors. So let me just go through mentors and their contributions, just like a chart. So give me 3 to 5 mentors, one at a time, and a synopsis of what you've learned from them.
Yeah. So for me, mentorship has meant everything to me. So I came from a family whose parents my parents did not go to college. I'm an only child, and I myself dropped out of college when I was second semester, first year, I believe. So I was not primed in my life to be someone that was going to go on to become a doctor. I didn't have that in my pedigree. I wasn't really encouraged to do that. I didn't have any people to look up to who did that. And I was actually a manager of a grocery store while I was in college. So all of the success that I have up until this point is due to mentorship. And it still is due to mentorship. If I had to list a few people that have meant a lot to me, the first one I would mention is even before I met you. His name, and he's passed away, his name is Subrato Chandra, and he was faculty at the University of Central Florida, where I started my undergrad. And he saw that I did well in one of his courses. It was engineering economics, and he saw that I did well in that course, and he must have seen some potential in me, and he offered me to be a TA, a teaching assistant for his class. And this was when I was trying to find myself. And I took him up on the offer. I had to quit. I was working at a grocery store at the time for Publix. And I quit that job, and I started to work for him. And I really sort of fell in love with academics, with teaching, with engineering. And he sort of took me under his wing. He became a mentor of mine for my undergraduate honors thesis. And I won the best thesis in the university, University of Central Florida, with his mentorship. And he really sparked my interest in really in academics and in research. So, he was and if I didn't meet him, if he didn't offer me that job, I don't know if I would have done what I'm doing today. I don't know. It's really interesting to think about that. I would say the second mentor, I'll mention Rich Melker. I already mentioned him. He was an important mentor of mine. He was one that when I was trying to find myself, I knew I wanted to do a PhD. I was interested in Florida. I was at University of Central Florida at the time. I noticed that he had an MD PhD. I looked him up online. I was looking up faculty who I thought had an interesting career. I found him online, sent him a cold email. He responded. He said, hey, how can I help you? I drove up to see him from Orlando to Gainesville. I met with him. He sort of, again, kind of guided me. And he ultimately became my main PhD mentor during my PhD, and really helped me through the MD PhD process. There are others. I will mention you as my third, of course. The interesting thing about you, and I don't want to toot your horn too much because we're doing this, and I don't want to make it sound like I'm doing this just to be nice to you. The amazing thing about you as my mentor, so I met you almost 25 years ago, and I was just starting medical school when I met you. And the amazing thing about you is that we're still doing this. Like, if I think about medical students that I meet today, which is basically when I met you, you were about the age that I am now. So when I think about if I'm now you when I met you, and I think about, okay, are any of these students because I work with students every day and I mentor them and I write letters for them and everything. But I think to myself, are there really any students that 25 years from now, I'm still going to be mentoring? That's a tall mountain to climb. That's a hard thing to say, yes, I'll be doing that. And you're doing it, not only with me, but with many other people. And you to this day still help my career, which is remarkable because there are things that I do. If you look at my CV and you look at the papers I've written and some of the things that I've done recently, a lot of them are things that you invited me to do, that you participated with me in, that you mentored me on, and that you were a part of, even to this day, 25 years later. So I tell people all the time, because I'm at a stage now in my career where I mentor junior faculty and I mentor students and I mentor residents and fellows. And I tell them no matter what stage you're at, you still need and would benefit from mentorship. And I always talk about you and use you as an example of that for me now, because you still do it for me. So in my career, I've had people like you, like Dr. Melker, like Dr. Chandra, and others who, had I not met and really, collaborated with and allowed them to help me, who or didn't volunteer to help me, I would not be doing what I'm doing today. So great question. And it's one of the most passionate things that I love talking about.
Well, I mean, I think it's often neglected. People talk about technical skills and board scores and research papers and various things, but it worked the same way for me. I mean, it's a much easier with a guide.
Yeah.
It's much easier with someone. Yeah, and also being a mentor all by itself is a lot of fun. Maybe without mentees like you, I would have retired. But it just the other day, a mentee of mine who works in food and addiction asked me about something related to, could food and addiction or highly processed foods become part of the DSM? How would that process go? What kinds of information do we need? And those are the kinds of things you can do at my age. It's pattern recognition, what works and what doesn't work, rather than how to invent a treatment for opioid withdrawal, or what you might do to reverse or change the brain so it's the same way as it was before someone used drugs of abuse. Anyway, it works both ways, and of
Yeah.
course, I enjoy working with you very much. I thought I'd ask another thing, because my daughter sensitized me to like wellness and thinking about how people manage their career and home life and everyday stresses of being a human, and then the extra stress of, I mean, think about, you went from working in a grocery store to being a professor at Yale. I mean, there has to be like stress in your life. I've been in high-powered academic positions and understand that. Like, how do you manage your own stress? And you appear so mentally stable. How's that possible?
Yeah, I just want to add one more thing to the mentorship conversation. I would always joke back when I was in med school with you, I would joke to people that you seemed to take more pleasure when one of your trainees did something than when you did something. And you would always brag, oh, I trained
Definitely,
them, I trained them, I trained them, right?
definitely,
You still do it. And,
definitely.
and, and now I realize why. Like, when one of the people that I help sends me an email, oh, hey, I did this, I got into that, I accomplished this, we got this paper published, whatever it is. In many ways, that's a better feeling than when I do something. It's a better feeling, and I like to brag about it too. And anyway, it's I now know why you do that. So wellness. I mentioned my sort of background, and I came from sort of a winding road. Um, I've been lucky to be with my wife for a very, very, very long time. And I actually met her right when I dropped out of college. So when she and I first got together, I had just dropped out of college, and I had no intention of going to medical school. I had no intention I didn't know what I was doing. I was working at a grocery store, like I mentioned, Winn-Dixie at that time. I was a front end manager of a Winn-Dixie. And I was, sort of trying to figure out my life. And she and I have been together ever since. And she's been a stabilizing force in my life. You go through ups and downs when you go through a medical school, which is, you move multiple times in your life. You go through medical school, which can be very stressful. You're trying to do a PhD and finish that, which is stressful. You're an intern, you move to another state, you do internship, you do it in fellowship, you're taking a faculty position, you're at Yale, you're trying to keep up with, all the people at Yale here, and doing the research and publishing and all my responsibilities here. And yeah, things get challenging. And my wife has been a source of support for a very long time. Uh, as far as what I try to do to stay healthy, I feel very strongly that we need a work-life balance. Work is really important, and I have to love what I do. If I don't love what I do every day at work, then I'm miserable at home. And work is a large percentage of your waking life. It's a lot of what you do. So for me, I have a great job. I have really good support. I have a good supervisor here. My chief is great. The department is fantastic. And that's why I wanted to be here, after fellowship. I wanted to be here because I enjoy it. So for me, part of my wellness is that. The other, and I do have a separation between what I do at work at home. I try very hard to not bring too much work home with me. I have some supervisory responsibilities. I have to answer phone calls and stuff, but for the most part, I am able to separate what I do at work and what I do at home because I've been able to create a good work-life balance. And for me, a lot of my wellness has developed into exercise. And my wife and I did an Ironman a couple years ago, and we still do triathlons and marathons and things. And we spend a lot of time together, my wife and I, mostly in the mornings before the kids get up, to have our time together as a couple. And a lot of it is spent, exercising and being healthy and making sure that we're doing the right thing. And it's a big stress relief for us. And it's a good way for us to work on our relationship where we have our me time together. And I do have 3 children who are now, the oldest is in high school, the youngest is 8. And, we're very busy with them. So, I'm not perfect, but I've done a good job with having a balance in my life of being at work. When I'm home, I'm at home. My wife doesn't work, which really helps us. She's able to stay home and take care of the kids, and she volunteers at the school, and, she maintains the house very well and does, sort of that aspect of our life. And I work and provide for the family, and that balance has worked very well for us. And we've been able to do well.
Well, that's great. And, I'm thinking about some of the things you said, and like one was you wrote a cold email to Rich Melker, who was a professor of anesthesiology and world-class inventor. And that took something. I mean, just to be able to do that. And then he wrote you back. So the 2-part question was, how'd you get up the nerve to write this email? And then the second is, do you do the same thing if somebody was to email you about your career in addiction?
Great questions. So when I was, again, undergrad at the University of Central Florida, I was trying to explore what I wanted to do. And I was doing this research project that I mentioned where we were building 3D models of bones and
Right.
giving them to orthopedic surgeons. And that was the time when I was really trying to figure out, what am I interested in? What do I want to do? And I wanted to do, my thinking was, I'll do a PhD in biomedical engineering. That's sort of the best case scenario. I'll get some medical exposure. I'll use my engineering knowledge. And I was at that time trying to figure out, where do I want to go? University of Central Florida did not have a program. Florida did. It was new, but Florida had a program at that time. And I was like, okay, let me go to the website. Let me see who's out there. Let me look at some people and, try to figure out what to do. And I was researching some people and looked like I said, and I found Rich Melker online. And, he had a PhD. He was an anesthesiologist. He had a lot of devices, a lot of inventing. And I thought, what the heck? I mean, what do I have to lose if I send him an email and just say, hey, I'm an undergrad at University of Central Florida. And I've sent several emails like this, and not everybody, in fact, most people don't respond, I would say. But I emailed Rich Melker, and he said, yeah, just, how can I help? What do you need? And I remember driving up there. I was not a student at Florida. I had not gotten accepted to the University of Florida. I drove up to meet him from Orlando, which was a 2-hour drive. And I met with him. And I'm just a random undergrad at another university asking this guy for help, like just for advice. And he's the one who, I'm giving you a little more detail. During that conversation, he's the one who convinced me to go to medical school. And I said to him, I'm an undergrad in engineering. I have not taken biochemistry. I've not taken, microbiology. These are requirements for medical school. I'd have to take a year off. And I don't know if I want to take a year off, and he said, it's only 1 year of your life. Who cares? In the grand scheme of things, it's no big deal. He convinced me to move up to Gainesville a year early, which I did before I got into med school. I shadowed Chris Badich, who was another mentor of mine at the University of Florida in the Department of Biomedical Engineering. I worked with him, who really helped me. I worked with Rich Melker, and ultimately I got into med school at the University of Florida. So it was that email and his response and that conversation with meeting him, which really jump-started my career into medicine. So you never know what happens when you send these emails and, who might respond. And if someone else would have responded and he wouldn't have, I don't know what I'd be doing. Again, it's very interesting how life goes. Now, to answer the second part of your question, I get those emails fairly frequently. I think there's like a list of people at Yale that people just email and say, I'd love to work in your lab, or I'd love to do research with you. I love what you're doing. Like I said earlier, I don't run an R01 lab where I can just, bring people in and do research, but I respond to the emails. Now, I will say in the past few years, I've brought in 3 postdoc fellows, all foreign medical graduates who are interested in psychiatry. So 4 years ago, it was Mohammed. 2 years ago, it was a different Mohammed, and currently it's Khaled. And all 3 of them sent me a cold email saying basically what I said to Dr. Melker. I responded to them, and all 3 of them, it turned into, they worked with me. They moved to Connecticut. They worked with me at the VA for an entire year. They shadowed with me clinically, and they did and you could look at my CV and see all my papers with them. They wrote many papers with me. And I was successfully able to match the first 2 Mohammeds into residency. And Khaled, that's what we're working on now. He's here with me now. We're trying to match him into residency. And they look to me now the way the first 2 Mohammeds look to me, the way I look to you and the way I look to Rich Melker. And it's a good feeling. So I'm able to help them in their career, all based upon a cold email that they sent asking for help. So I do try to give it back that way. I'm limited into how much I can do, but I do try to give it back that way. And it's a great relationship that I've built with all 3 of them.
I wouldn't expect anything else, and I'm really happy about that. That's just wonderful. So let me just ask, you're at Yale, and it's the #1 addiction psychiatry program, and I think also it would be the #1 research to innovation program in the United States. When you look around Yale, what's out there that you're the most excited about, that maybe we don't know about, or maybe we haven't thought about in the detail that you have for psychiatry and addiction psychiatry?
Psychiatry has always been a field of medicine that I feel has just sort of lagged, some of the innovations of other fields, and particularly within the world of addiction. We don't have much as far as treatment options for many of our substance use disorders, right? If you look at diabetes, blood pressure, many have dozens of medications to choose from, and all these new things coming out. And we've struggled, for opiate use disorder. We have a handful of meds. They're pretty good, but they're not great. And they're good, but they're not perfect. And we need more. So what are the things that are exciting? I'm sure many people are probably aware of the GLP-1 agonists, which is sort of coming out, and they're being used for obesity. In diabetes, and there's a lot of anecdotal reports that they help with cravings and with decreasing use. Some concern about depression and suicidality and some dopamine deficiency, but I think overall this might be a really interesting thing coming down that we'll have to sort of monitor and see if this turns into something helpful. I think the interventional approaches, the neuromodulation approaches to treatment is another really important thing. We do some of that in psychiatry for general psychiatry. TMS is something that they're looking at using in the world of substance use disorders, something that could be helpful. There's others, like involving ultrasound and others. We don't have to get into detail with them, but deeper in stimulation. But I think some of the neuromodulation may be something that may take off down the road. The psychedelics have, a lot of interesting characteristics. There's a ton. One of my colleagues, Chris Pittenger, who I work with regularly here in the psych emergency room, is an expert researcher in that world, and is really trying to, work on breakthroughs for treatment, both for psychiatric and substance use disorders, using some psychedelics and some therapy. Contingency management has actually been found to be quite helpful, which is where you pay, you give patients a small amount of money or something else that is incentivizing usually for negative urine drug screens. And that's actually, there's a lot of evidence. And there was a big symposium at the last AAAP meeting about, the role of contingency management. So, I think there's a lot out there that people are looking at. I think there's a lot. I think the landscape of what we do will be quite different 10 to 20 years from now than it is now. I mean, that's maybe an obvious statement, but I think there's a lot going on that, I think we need more. we need something other than the 3 meds for opiate use disorder, the 3 meds for alcohol use disorder, and some therapies that often people have a hard time, obtaining. We have AA and NA, which I'm a huge advocate for, and very, very helpful and life-saving for many people. But, we need more.
Well, I mean, that's a good landscape. And of course, we need more. I mean, most of the treatments are the same as when I was at Yale. I mean,
It's true.
Kleber and I were giving naltrexone in the early 70s, and we had methadone, and we Suboxone is also an old treatment. These are really old treatments, and they're kind of limited to the taking the medicine, and then also limited in the sense that the person has to be an active partner in their treatment. You don't have to be an active partner in your treatment, really. If you have strep throat, you don't have to believe in the treatment when they give you penicillin. You don't have to do anything but take the shot right off the bat, and it works almost against your will. We have nothing like that in psychiatry. We also assume that these kind of, even something as an extreme as an overdose doesn't count like a concussion. I mean, you look at most charts, you can't even tell how many times a patient is overdosed, how many times they've lost consciousness, how many times they've had a reversal with naloxone or nalmefene, how many times they've had head trauma, subsequent fights, arguments, and again being unconscious. So the TBI effects are tremendous. And that's all coming back into focus with this ABCD study and people looking at sequential brain imaging. But anyway, I mean, I think you and having, hundreds of people like you out there in the field now, rather than 5 people starting a discipline, means we're more likely to be successful.
Yeah.
It's funny you mentioned neuromodulation. Did you happen to notice that was my article today in Psychology Today?
Imagine that, huh? Yeah.
I'm glad you get that.
I have to admit, I love your articles. I read them every day. I get the email, I get the text, I read them right away. It's 5-minute read and it teaches me.
So when you think about our field, one thing that stands out for me as a big challenge is, and you've had experience now in both of these realms, why is it that an impaired health professional, a doctor, maybe a doctor that you worked for, why is it that they could develop a substance use disorder and be treated with detox, abstinence, caduceus meetings, and have a 5-year, 80% drug-free outcome and return to work, and a similar diagnosis, if you will, of a different person is treated completely differently?
So, this is, again, back to my days with Scott Teitelbaum in the Florida Recovery Center, where we treated so many impaired professionals there. And part of it, I think, is the external motivation of getting back to work and maintaining a medical license, right? So if there's a hammer, what we would call a hammer, or an external motivator. So if someone comes in and they're a physician, and in order for them to continue to practice medicine and get back to work, I have a 5-year plan as to what you need to do. I need to get you on this medication, or I need to get you to go to 90 and 90. I need you to get, going to meetings every day, finish the residential program, continue with your, with your meetings. I need you to check in regularly. I need you to, give urine drug screens. And I have a 5-year plan for you that's comprehensive and thorough. That plan works very well. As you mentioned, numbers upwards of 80% or higher of maintaining sobriety, even 5 years out. But if that same person doesn't have that hammer, right, there's no external motivator. There's nothing where I can say, if you don't do this, then this consequence might happen to you. It's a little bit more challenging, right? There has to be then a much greater sense of internal motivation for them to make that change. Internal motivation is really helpful. And at the end of the day, we usually need it for maintenance of their treatment. But initially, the external motivator can be the thing that we need to get them to get the ball rolling initially. And we often have that with impaired professionals. Also, impaired professionals often have access to more resources, whether it be financially or have better insurance, or again, understand that they have to do something, so they pay for it. I think it's evidence that if someone had access to resources and we were able to properly motivate them, our treatments are pretty good. 80% in 5 years, that's pretty good. And if we could offer that same level of care and that same amount of resources to everybody, again, can you have that hammer, that external motivator for everybody? I don't know. That's challenging. But if we can, then our success rates are pretty high.
What about this? What about thinking like early versus late onset disease? And maybe they're more than one disease. Just because a person meets criteria for opioid use disorder doesn't mean they're the same.
No, I'm sure. Just like high blood pressure, just like diabetes, just like cancer, we shouldn't lump them all into the exact same basket and say everybody. We practice individualized. There's a lot of language in medicine now, but individualized medicine, which is we have to take everything into account. And in one of your articles, I forget which one, you did an article on dual diagnosis. Maybe it was one of the myths, actually. I think it was in your myth article. And you talked about the myth that most people with a substance use disorder do not have dual diagnosis. And that's a myth. The vast majority have depression, anxiety, bipolar disorder. And these are the type of things that I mean when I say we need to practice individualized medicine for every person. We don't just say, oh, you all have opiate use disorder. It's all the exact same treatment. Instead, it might be you need this level of care with these medications for this other comorbid stuff that you have going on. And you might need this level of care and buprenorphine, and you might need methadone and something else. So you're right. I mean, it's not all the same flavor. Everybody comes in a different flavor, and we need to think about that when we're treating everybody. But we don't have a ton of treatment options. So
we don't have a lot of
we don't have treatment options, so it's a little bit limited.
Well, it's almost easier for us to treat somebody who's a physician opioid addict than it is to treat a 15-year-old, because the physician, you have to take them back 5 years, and you say, well, we want to return to that person. The young person who's developed a substance use disorder, what do they return back to? They just basically missed 4 years of opioid use disorder is not like going to the University of Central Florida.
Yeah. And, I gave a talk in the community years ago at a high school, and there was a family who lost their teenage child to an overdose. So this was at a very large public high school nearby where I live. And they wanted, we had a panel, police officer, paramedic. They had me as a doctor and a specialist and several other people. And we put together this big opioid panel designed for parents to educate them about the dangers of drug use for their children. And we marketed it. We had the town first selectman, who's like the mayor of the town, showed up. It was a whole big thing. And there were like 5 parents that showed up, and the 5 parents that showed up were all parents who already had kids that were struggling with drugs. None of the other parents came. And I think it gets to that point that everybody's different. The younger people, this will never happen to me. Even when it's happening to them, they feel invincible. The parents often live in denial. This would never happen to my kid. Very different than if you're trying to treat a 50-year-old doctor who was previously high functioning and doing very well and has lost a lot. So these are very different things. And also in AA, there's a concept of a bottom. And for professionals, a bottom might not be that low. Like if I was developing an alcohol use disorder, for me, it might be my chief one day says, Brian, I smell some alcohol on your breath, and someone noticed, if you don't get some treatment, we're going to have to, look at some disciplinary stuff. That might be enough for me to say, I need to get better. Nothing else happened, right? No DUIs, no marriage dissolution, no children who won't talk to me, none of that. Just a simple conversation with my boss versus other people who, struggle despite major consequences.
So we're going to try to wrap up. So I'm going to just hit you with some quick ones.
Yep.
And you give me quick answers. Like if you have a patient with an alcohol use disorder, what's the go-to medicine and psychosocial treatment?
Yeah, so I would still say referral to residential treatment is usually recommended depending on the situation. Naltrexone or IM naltrexone is still usually the first choice of medication, and I would always have them do 90 meetings in 90 days, get a sponsor, work the steps, and treat whatever comorbid psychiatric conditions they have. So follow up with a psychiatrist and if take meds if indicated.
How about a teenage cannabis use disorder?
Yeah, so again, that age group is challenging because, again, I'm invincible and nothing will ever happen to me, and cannabis is natural and it's not going to harm me. But if there's a clear cannabis use disorder, again, with the patient who's willing to engage in treatment, the psychosocial interventions are usually the best. But you also want to have therapy for the child, depending upon what's going on in the child's life. Did something lead to this? Is there a history of trauma or abuse? Maybe, maybe not. Is there depression, anxiety, or the difficulties at school? So you want to have intense counseling therapy. You want to make sure the kid's on the right track. And then if willing, again, we want to get them into, some kind of an AA/NA type of program.
So, when we do talk about all the medication-assisted treatments, that doesn't really apply to psychostimulants. There's no treatments for overdose. There's no naloxone, nalmethine. There's no treatments really for craving reduction. What happens then? We're in the middle of a psychostimulant epidemic. What do we have to offer?
I mentioned earlier, the majority of the patients who come to the psyche are with a substance use disorder. They are alcohol. What's common is common. But second is cocaine. Cocaine here in this part of the country, for my population, is far more common than opiates. No medications, like you mentioned. There's some off-label medications that can be helpful. Contingency management we do have available at the VA has some significant evidence for stimulant use, but it's difficult to implement that. In fact, at the AAAP meeting, they were talking about the payment that's necessary to motivate people often exceeds the one-time payment necessary where you have to file for taxes, and the patients would need like a W-9 or whatever the tax forms are, and no one's doing that, so they pay less than $600, which is often not motivating enough in today's economic inflationary, So anyway, but contingency management does have some evidence. Obviously, AA and NA, is always useful. CBT for addiction is very useful. Smart recovery can be used. There's a lot of psychosocial options. None of them are fantastic. We don't have meds, and the stimulants are just blowing up. I mean, they're just really blowing up. We don't see a ton of meth. I know they do in the Midwest and the West, but we see so much cocaine.
Well, because cocaine, they had record crops this year and record production, and they're competing with methamphetamine that's just made in a lab. But I did, in one of my articles, point out that we were going to shift into psychostimulants when everyone was talking about opioids and fentanyl, just because one of my teachers, when I was at Yale, David Musto, said that every opioid epidemic is followed by a psychostimulant crisis, and we're in the middle of that now. Again, it points out to me that prevention is the best and most effective treatment. You develop an addiction, it tends to be chronic, lifelong, and relapsing. We haven't been able to interrupt the natural history of addictive disease. We've been able to manage it, if you will, but not interrupt it and not reverse it. Even the opioid use disorder medicines, wouldn't you agree?
Yes.
When we give somebody Suboxone or methadone, yeah, it works to prevent overdose death, but the day they stop it, they have about the same risk as anyone who didn't take treatment before. The treatment benefits don't go on forever.
Yep, they're not curative. They're maintenance treatment that keeps the addiction under control. And people can live the rest of their life without using and without relapsing, but it's not, the disease is not cured. So also, it requires a lifelong commitment to something.
Right. And they also can then pick up all the other addictions that are out there. But I did want to say thank you. Thank you for your career. Thank you for training so many addiction psychiatrists. Thank you for leading the field forward and giving everyone the sense that we're making progress, real progress, and things are going to be better now than they were when I was at Yale in 1975.
Yeah, I think the last thing I'll say is the other thing that we've moved forward. I think is we have a long way to go, but is stigma. I think through education, again, that's one of the other things I do in my career, through the education process of up and coming people that are going to join this field, educating the public, educating doctors, educating everybody that this is not as simple as a choice. It's a disease process. We need to, we need to help patients to recover and get better. And I think if we can change the idea of stigma and treat this as we treat other illnesses, I do think we can move forward with that way also. This was a lot of fun. It's great to see you as always. Thank you for everything you've done for me in my career and for the field, obviously the field of addiction. You're one of the fathers of the field of addiction, as you mentioned, and you've done a lot and continue to do a lot. So of course, thank you as well.